no other ocular pathology, and no previous ocular surgery. So for beginners, this is a good way to start off. Of course, there are much more complex scenarios, like Dr. Ramurthy elaborated, that we can implant ICLs, but for a beginner, we would start with the simple cases. So what equipment do you need to begin the practice? So your very basics, such as your slit lamp, your indirect ophthalmoscope, your 78 to 90D lenses, tonometer. Every patient needs to undergo gonioscopy, retinoscopy, a very good retinoscopy, both subjective, objective and dilated refraction, a pupillometer, and an ultrasound biometer with a pachymeter is enough. The auto refractometer and keratometer, a digital caliper, and a topographer. So among all of these instruments, your normal cataract practice would have everything except probably your digital caliper, your topographer, and your pupillometer. But is a topographer really required? Like Dr. Sudarshan elaborated, the digital caliper is one of the most simple and accurate methods of measurement of your white to white. The topographer basically confirms that measurement, and also every refractive practice requires a topographer, and it's also very helpful in ruling out your keratoconus cases. So again, your OpScan is a very good topographer to actually measure the white to white. It has one of the most accurate measurements, but in some cases it can give you a wrong measurement. So there's a tool called the iMetrics tool where you can manually correct and measure the white to white. So it gives you a correct value. Now, in an ideal setting where you can have anything you need, what are the additional equipment that you may consider purchasing for your ICL? So we have the MS39, which gives you a very high resolution anterior segment OCT, along with topography. You have your UBM, which was spoken about, which gives you your sulcus to sulcus, and it also gives you the simulation of how the ICL would look in your sulcus to sulcus, which helps you with your measurements. Your ASOCT, which again measures your lens rise and angle to angle measurements. Pentacam, of course, for topography. Again, Pentacam may slightly overestimate the white to white. Specular microscope for the endothelial counts. In very young patients, you need to make sure that the endothelial counts are 3,000 to 3,500, and your minimum should be about 2,000. The IOL 700 again is for your biometry, your axial length, your anterior chamber depth, but IOL 700 also is known to overestimate the white to white. And your eye trace for the aberrations, again, like Dr. Ramurthy explained about in highly aberrated eyes, it may not be a good idea to go ahead with the ICL. So just to rule out highly aberrated eyes where you would rather do a wavefront guided LASIK, and also for postoperative patients where you want to rotate your ICL, it can be useful. So in our center, we have this form where we take all the measurements. So as you can see on the left-hand side, you have your ACD, where 3 measurements are taken. 3 measurements of the white to white are taken, both for the right and the left eye. And the iMetrics tool on the OpScan is used for the white to white measurements. Your K1, K2 has to be entered, your corneal thickness, and your refraction for both the right and left eye. And here you can see some of the values C1, C2, C3. This is actually obtained from your UBM, which I'll come to a little later. And then your anterior chamber angle and lens rise is also mentioned in every sheet in our workup. So this is a small video just showing you how our patients are worked up in our center. This is the auto ref which is done, which can also measure the white to white. The